We're going to start our second session of this workshop and kind of shift gears a little bit and start looking at the question of how do we raise the prominence of regulatory systems and investment in regulatory systems. We have 3 speakers lined up before lunch. We have an early lunch break at 11:30 to accommodate one of our afternoon speakers' schedule. So that lunch at 11:30 is real on the schedule, and we'll be breaking then to allow the committee and our guests time to get lunch in the cafeteria. But I'd like to now introduce Carlos Santos Burgoa, who introduced himself this morning when we ran around the room. He's a professor in the Department of Global Health at George Washington University here in Washington, D.C. And he's going to talk about regulatory systems and public health.
Well, good morning, everybody, and thank you very much for the invitation. I am really excited to be here, and I congratulate the National Academy of Sciences and the Food and Drug Administration for doing these kind of workshops. We do need this dearly. How do you do this? How do you move it? It's not working. Or if you can move it for me, you will move it for me? Okay, thank you. Okay, so I will talk first about regulation as a public health function, then talk about turnaround on public health regulatory institutional capacity, with special emphasis on financing health regulatory institutions, and some notes on the future for development. Next one, please. Let's start from the basics. This is a little bit of the history of risk identification and protection. Those of you who are from public health might know this story, but there was this person, this doctor, John Snow, in 1854. He was an anesthesiologist and doctor in London. There happened to be an epidemic of cholera in 1854 because of several practices that people were having in their daily life around. Nobody knew exactly what cholera was, how it was transmitted, and all that. So this doctor gathered the evidence of what was the situation of the epidemic, and found out that there was a water source that had the whole problem. So he went to the area council and sat down with everybody and said, hey, there is a problem with this water pump. We have to close it. And say, how are you going to close water? These people need to have water. Yeah, but this is contaminated water, and they are dying from that. He gathered further evidence from prisons, from other sources, and with a lot of tension, a lot of discussion, really, this was a private pump, so even the company that was operating this pump, and he had the challenge of that. Eventually, he managed to convince everybody, after several days, that the pump had to be closed. He went with the police, and he managed the health authority and closed the pump, and the epidemic went down. Was eliminated. That was, he said, to be the father of epidemiology. I say he's the father of public health regulatory capacities. He actually did the whole process on how to manage and to do public health regulations. And he generated an impact, a very clear impact. Next one. Next one, please. So there are many classifications of what is a public health function. The WHO identifies 17 versions of this one. I'm just getting one of them, and one of this public health function is strengthening of public health regulation and enforcement capacity. That CDC, PAHO, and several organizations use this as a consideration. Next one. Here, I think that what we have to think is that regulation is a primary responsibility of health. And that comes because the function is to protect. What we're doing is to protect. In some countries, the protection of health is a constitutional right, and not everybody, not everywhere. It's a responsibility of the state, and it's a responsibility of governments on health, and that is by international law. The WHO Constitution that was signed and ratified by 195 countries have this as a mandate, an international law and law in every country, that's the responsibility of governments. It leads to innovation, and we were just talking about how to deal with Ethiopia. Well, it leads to innovation, okay? How we change the ways we do things. It is non-delegable. You cannot give it to a private person to do the regulation. It is done by the state. It produces common public goods, things that are non-excludable, non-rival consumptions. This is for everybody. Once you establish a regulation, that is for everybody to be benefits. And most importantly, it's results-oriented. It generates an impact. So we have to identify this, and that's the important thing. Our impact is on public health. We want to produce healthy life years. We want to reduce disease burden. We want to reduce human and health security and increase the sustainability of the health system. And yes, eventually contribute to labor productivity and development. The next one. And this is, here you have a graph on the impact. And this is for the Americas, where I have worked. Sorry, a lot of my data comes from the Americas. That's where I have worked a lot. And this is NCDs, non-communicable diseases, and the capacity of regulatory agencies in the countries of the Americas for 2014. And basically what you have is the more the capacity of the regulatory agency, the less the burden of NCDs that you are going to have. It can be clearly measured. And the less burden of NCDs, the more productivity you will have, and this will impact labor productivity and development. The next one. So one thing that we have to acknowledge is that, yes, regulation influences the economy, and it is really linked to the economy. It is said, for example, in Mexico, that 44 cents for each peso of families spent is under the public health regulations. It's a lot. Might be an overstatement. But we have estimated that for 18% of the commerce of the NAFTA trade between United States, Canada, and Mexico on non-medical goods, it's under the power of the regulatory agency. So it's a sizable proportion. So commerce can be used for leverage on regulation. Although public health regulations are not at the service of commerce, but we can use that as a leverage. International trade is key, and development is a factor. But something that we have to also think, and people don't always talk about that, is that regulation can be a modulator for equity. And we can modulate our regulations to improve equity in a very unequal world, especially in developing countries. The next one. These are just some of the people that we have to refer in order to understand regulatory capacity. I started with John Snow, but Amartya Sen on development and human security, and Douglas Becher on public health functions, and so on. Very importantly, Jean Tirole on regulatory economics, and George Stigler on regulatory capture, and Douglas North on institutional economics, and more recently, Mariana Mazzucato on the value of the state and how it provides value for development and innovation. The next one. When I was working at the Pan American Health Organization, we developed this scheme, and basically what you have is what was mentioned before. the whole integrated public health regulatory process that starts from the risk analysis and decisions on how we are going to manage this. Eventually, some of that can be regulatory and cannot be regulatory. Very important, the risk characterization that was explained in the previous presentation. But then, if we decide to go on the regulatory, on risk regulations, we have to make the standards, the regulatory process, the norms and standards setting, and that is a whole complicated process. But then we have to go into the implementation, enforcement, and evaluation of that. And here is where the critical path comes. How do we develop this whole process that will end up and has to end in a final evaluation of the process to feed back the whole thing. The next one, and this is critical. So if we have an implementation performed at the national, federal level, and also will have to be performed, as it was explained before, at the subnational and state, local, district level. And here, this is the challenge of a lot of the regulatory processes. How we take this to the local level. And that a lot depends if it's a central government or a federal government. How do you enforce this? How do you monitor? And eventually, how do you evaluate? The federal government has to follow up for implementation, has to develop coordination agreements, technical, and yes, assure financial resources to the local level. But there are local resources as well to develop this. The next one. And yes, so those two parts are extremely important to think that has to be done eventually, right there at the local level. The next one. Next. Here you have a scoreboard of one of the biggest strategies now that the World Health Organization has. It's on NCDs, and there you have different policies. Some of them related to food, food marketing, salt policies, trans fats policies, marketing to children, and you can see just by watching at this scoreboard that after 10 years, more than 10 years of this initiative, the rates are very high throughout all this scoreboard. Of all the indicators, of the 10 indicators of this strategy, most of them demand regulatory capacity. And that is for the whole world. And this is just a scoreboard for the Americas. So what we have been working on this, and say we just don't move fast enough. Next one. Here is the one of the biggest challenges is the complexity of what these agencies or these institutions of or ministries have to regulate. Here you have the example of the Mexican COFEPRIS, the regulatory agency that has all these areas. It's a huge list of areas that have to deal with this agency, and it's very hard to really tackle everything within the same agency. To have a correct balance, and that has been one of the biggest difficulties. In this case, in spite of having a strong agency, the balance is quite difficult. Sorry for the Spanish, I didn't have the time to translate. Next one. Here is the status of the regulatory institutional capacity and in the Americas that was just presented 1 month ago at GW by the assistant director of PAHO. Basically, what this shows is that in the region of the Americas, we have only eight independent, autonomous, or agencies that handle regulations, public health regulations, FDA equivalents. The other ones have to work within the system. That means they are going to deal. They are part of the infectious diseases department, and they are going to do the implementation, and that weakens a lot the capacity to respond. The challenge, as it was mentioned before, we have a widespread informal economy and large quantity of micro businesses. Very difficult. We do have also strong national and global corporations. And that is also a challenge for all these organizations. Like the pharmaceutical industry is heavily consolidated, and they confront the national authorities having all the power of the pharmaceutical industry, the chemical industry, the processed food industry, the alcohol, tobacco industry. And this really leads to problems of interference of industry and regulatory capture, and impacts governance. And that is really a challenge when you do have this spreading of the regulatory authority. The next one. So what I see is basically that we have to think of how do we change the weakness of these organizations. And people think constantly, okay, how at the end of the line we are going to reduce diarrheas, or how we are going to assure that we have low pesticide levels in our food chain. But if in the bottom, in the infrastructure of the regulatory infrastructure, we have weakness, then the delivery at the top, it will be really impossible to have something well. It was shown, the laboratory that was shown in the previous presentation, that's a good example. We have to look at the human talent, at the technology, and the organizational alignment and culture, and it is essential to look to all these factors at the same time and say, okay, we want to strengthen this in order to deliver the public health functions, the regulatory functions, and eventually the value that we have to provide in the next one. And for this, the financial component, I would say, is critical in developing countries. Okay, we have to think in this component. How the financial flows happen. The next one. Most of our institutions that do health regulation belong to ministries of health. And ministers of health are confronted with a false dilemma. Do I put my money in medical care? Everybody is asking for that. Everybody is asking for medical care. Do I put my money there versus do I put it in health protection? Nobody looks at that, and in fact, people hate it. Should I take money out from healthcare, medical care, and put it in regulation? That's a false dilemma. The financial flow is critical for effective public health risk protection policy. We have to think in two different tracks. One, if the regulatory authority is going to produce a public common good, such a norm, a standard, a guidance, that's for everybody. That has to go and be paid by taxes. But if it is going to produce a private good, a license, a certificate, a registration, that has to be paid by fees. There is no reason why tax money, public money, has to go into supporting private goods. This can be adjusted for equity. Okay, if I want to make people who are a small business or poor business to enter the formal economy and produce better products, then you can make an explicit policy for this. But I would say these are the two main criteria that I would use to really increase the flow and combat that false dilemma. The next one. Here you have an example. You ask yourself, here you have new, the cost of registration of new drugs in different countries, in thousands of dollars in the last column. From the United States, that has $2,374,000 to India, that has $1,000, or Brazil that has $69,000, or Mexico that cost $7,000. Why so different? What are they paying for? It looks, how they came up with this money, with these rates, I don't know. The next one. And next one. Here is also a distribution, global distribution, but I'm running out of time, so let's keep on going. I am aware of lunchtime. And also, see, here you have high-risk medical devices and products. And again, the cost throughout the world in different countries are quite diverse, independent if they are very, very costly or not. And they don't seem to be related to how well the registration process is done. The next one. So, how do fees happen in general in countries? Well, they can go either straight into the national revenue or directly into the agency funds, or everything in between. Something can happen in between. If it goes everything to the general national revenue, basically nobody will be interested in trying to collect those kind of fees. If it goes into the agency, well, there will be some interest to collect those fees. So in between, there are several versions, like Anvisa, that sends everything to the federal government and then negotiates its federal budget, or like COFEPRIS that has a fraction of what is collected redirected to COFEPRIS. So there are general revenues from these sources, but also there are local and state taxes and collected fees that can be used. And all of this has to be considered how we can finance the regulatory capacity at the national, state, and local level. Next one. Now the problem is, how do we cost? And how do we use this revenue? And costs should aim to internalize the overall management of the product, from analysis to post-marketing and population surveillance, health surveillance, what we call the integrated process product cost. Really, to make, if we want to make explicit subsidies, to lower entry barriers to these businesses from the informal economy of the poor, that's one thing. But we have to really internalize the whole process. All this process, how much it really costs if we really want to do it right, okay? And really include that in the cost. The regulated entity should not have to contribute to the general expenditures of the regulatory body, and I think that is very important. But we have to offer to do with those fees, do good regulation, really reliable risk analysis, a good risk analysis from the startup, effective labeling, effective level field for all the actors. Good quality, performance, efficiency, competitiveness, foster innovation, and so on. So we have to offer something in return if we are going to really do this costing and put it into the fees. The next one. To finalize, yes, this is a general scheme of the world regulatory quality. Every regulation in the world by the World Bank. So this is a very heterogeneous map of the world and very red in many places. It's very hard. How we are going to manage public health in this, how we are going to reduce communicable diseases and non-communicable diseases and have increase life and support health systems, it is really a great challenge. The next one. So I do think that first, health systems have to consider public health regulatory institutions a key part of the health system, okay? And it is the first part of the health system. It's an asset, it's not a liability. I think that is a mindset that has to be changed. We have to position the idea, make it feasible, provide the social basis, increase the demand, yes, provide the economic rationale, and support the local leadership. It is essential for the health system sustainability, and that is in the case of the COFEPRIS in Mexico. That is how it started. When the health reform was established, the regulatory agency was established because trying to seek the health system sustainability. Now we have to focus support in terms of international aid or research on the needs for institutional capacity, and my focus would be on that. Let's really map the global capacity on this. Let's build methods for this integral process product costing that can help everybody to say, okay, this is how much it would cost in my country, and this is how it would have to be transferred, internalized by the regulated sector. Innovate the monitoring of supporting the process, the informatics, we just heard about that, health surveillance and impact evaluation. We have to visualize the public health impact of regulation as Jon Snow did. My key question to India, key question was, have you been able to show the impact, the health impact of your regulatory institution? It's very important to show it. And there is demand on that, and we have to do that. We have to work really on regulatory capture. The disadvantage of our weak institutions is important, to make this aware, to identify that, and to manage that hazard, that risk. It's real, it's happening. We just have to do it, but we have to do it with strong science and with strong capacity of the institutions. Identify the opportunity for innovation on the regulatory infrastructure, the talent, technology, and organization, and the process. And in the process, I think a lot of this has to be done through regional exchanges and comparative analysis, and foster professional associations to reposition this field in developing countries. This has to be in the future, one of the strongest areas of public health in developing countries, because this is an area where the rate of return is very high, and we can do a lot of things. Next, I think that's enough. Thank you very much.
Thank you very much, Dr. Santos Burgoa.